there have been a lot of prior efforts to see if it's adequate to shorten our overall duration of HER2-directed therapy to either, we've actually looked a lot at 9 weeks and we've looked a lot at 6 months compared to the current standard of 1 year. So there have been actually 5 previous large randomized non-inferiority trials that have tried to examine that. And all of those trials have shown really modest differences between the shorter duration. Again, that could be even as little as 9 weeks, and some of them looked at 6 months versus the standard duration of 12 months. But many of them didn't actually were not fully able to conclude that it was truly non-inferior to do the shortened duration. And so because of that data, even though the differences have been modest, we've continued to consider 1 year as our standard. That being said, none of those trials were making any effort to select a low-risk population. And so they were all purely adjuvant trials. So there was no data in those trials about how patients had responded to their neoadjuvant therapy. And we know now in HER2-positive early-stage breast cancer that how patients respond to their initial phase of neoadjuvant therapy is incredibly important in terms of helping us select who's going to have a favorable prognosis and who's going to have a less favorable prognosis long term. So none of that patient selection for a lower risk population or a treatment sensitive population, none of that was incorporated into the patient selection for those original non-inferiority trials. And yet, again, they all showed quite modest differences for the shortened durations. In addition, there was a large meta-analysis that looked at all 5 of those trials together and actually did conclude for the trials that were comparing 6 months versus 1 year, 12 months, that 6 months was non-inferior if you put all the data together from the 6-month versus 12-month trials. So we feel that, given the modest differences that have been consistently shown across multiple non-inferiority trials, overlaid with the fact that we now plan to select a really favorable risk population. These are basically stage 1 and stage 2 patients, all of whom are exquisitely treatment sensitive because they've had a pCR to neoadjuvant therapy. When we overlay that low risk population and ask the 6-month versus 12 months question, we're very hopeful that we'll be able to identify patients for whom 6 months really is adequate. Yeah, so again, the main important difference for ShortStop-HER2 compared to other non-inferiority trials that have looked at shorter durations versus 1 year is that we are selecting a low-risk population who are very treatment sensitive from the outset. And so this is largely a trial for stage 2 patients. We'll allow a small proportion actually of stage 1 patients who got neoadjuvant therapy, but it's mostly stage 2, so no stage 3 patients are allowed. So sort of anatomically already, it's a lower risk population by excluding stage 3. And then we are specifically only allowing patients who got neoadjuvant therapy, some chemotherapy and some HER2-directed therapy. It has to have been at least 12 weeks, which we'd usually call 4 cycles. Could have been longer, but it has to have been a minimum of that 12 weeks. And after that neoadjuvant chemo plus HER2-directed therapy, patients have to have a pCR, a pathologic complete response. So they already have to have sort of proven to us, their tumor has to have showed us that it's exquisitely sensitive to the chemo and HER2-directed therapy that they've already received. And so if those 2 boxes are checked, they're stage 1 to 2, and they've had a pathologic complete response to their initial neoadjuvant chemotherapy, then they're eligible to be randomized on the ShortStop-HER2 trial to either complete this current standard, which is a full year of HER2-directed therapy overall, or a shortened duration of just 6 months. So it's the patient selection for treatment sensitivity and lower clinical risk at the outset that distinguishes this from the previous trials. Oh my gosh, well, we're very hopeful that, shortening to 6 months as compared to 12 months could be really meaningful for patients in all of the domains that you just mentioned. And of course, we developed this trial, as we do with all of our trials, with patient advocates, involved right from the outset, helping us as providers to verify that they agree with us that this is an important, and meaningful endpoint for them. So I would hope that we'll be able to show that shortening duration to 6 months instead of 12 months is equally effective and better in all the domains you mentioned. You would imagine that obviously side effect burden is improved if you're giving 6 months versus 12 months of therapy. We know HER2-directed therapy can cause usually manageable side effects, but still some side effects like fatigue, diarrhea, especially if you're giving pertuzumab. So we'd like to, shorten the duration of those side effects. We know that a small proportion of patients who get HER2-directed therapy will have important cardiotoxicity, which can be short or in some cases even long-term, might need to start medications for cardiac well-being and things like that. So we're very much hoping that we see lower rates of cardiotoxicity with the 6 months versus 12 months. And then just as important, we are hoping that the overall quality of life, the ability to sort of return to whatever normal activities are meaningful to that patient, be it working outside the home or, responsibilities inside the home, ability to go back to making an income and doing that consistently if that's something that they were doing and was important to them before the breast cancer diagnosis. We're of course hoping that we'll be able to show that shortening by 1/2 the duration of overall therapy can facilitate all those really important outcomes in terms of sort of social functioning, social roles, financial well-being, not to mention how you feel, how much diarrhea you have, how healthy your heart is and things like that. So, this absolutely is a trial that I think falls under the category of de-escalation within HER2-positive breast cancer. But I think more specifically what that means is individualization. We don't want to de-escalate for everybody across the board because there are some patients who need more than our current therapies are offering, not less, and we would never want to, shorten duration for those patients. So I think in HER2-positive early stage breast cancer in 2025, the name of the game really is individualization and risk stratification and picking out patients who need more and patients who can be cured with less. And so yes, this is absolutely, part of that movement in early stage HER2-positive breast cancer. In terms of other patient groups that might be, appropriate for shortened duration of adjuvant therapy, one thing that I think is of interest, and we'll maybe be able to get into this data once we see the results of ShortStop-HER2, though it's not the primary outcome, is specifically in patients who are ER positive and HER2 positive versus ER negative and HER2 positive. It certainly, I think, stands to reason that the patients who are ER positive and HER2 positive, who are going to derive all the benefits from endocrine therapy, maybe they don't need as much in terms of the toxicity and the duration of their HER2-directed therapies because they have this other target, which is estrogen receptor, that we're going to be able to hit for them. So I think that's a really interesting subgroup also to think about in terms of how can we specifically individualize and optimize therapy for them. But that's not going to be the main goal of the ShortStop-HER2 trial. I just personally think that's an interesting area for investigation.